Hello, listeners. From the RSNA, this is the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath, and I am a radiologist from Dallas, Texas. In this podcast, we explore research advances and technical developments in cardiothoracic imaging through conversations with our authors, our editors, and experts in the field. Enjoy! All right, welcome back, listeners. On today's episode, we are going to be reviewing an original science paper recently published in the journal. The paper is titled Mapping the Spatial Extent of Hypoperfusion in Chronic Thromboembolic Pulmonary Hypertension Using Multienergy CT. This comes to us from our colleagues in San Diego. The lead author is Elizabeth Bird, and the senior authors are Dr. Seth Kligerman, Dr. Albert Hsiao, and Dr. Francisco Contijoch. This original science paper introduces a novel automated method for assessing CTEPH disease severity. The researchers examined multi-energy CT angiograms from 51 CTEPH patients and compared them with a control group of 110 patients. Using deep learning techniques, they isolated areas of hypoperfusion within the lungs and calculated the hypoperfused lung volume, or HLV. Their findings revealed that this automated approach accurately distinguished CTEPH patients from controls and had significant correlations with hemodynamic measures, even in cases of segmental disease. I had the privilege of speaking with the lead and senior authors of this paper, and let's jump into that conversation now. All right, welcome back, listeners. I am pleased to be joined by the lead authors of our featured paper, Dr. Seth Kligerman, Dr. Albert Hsiao, and Dr. Francisco Contijoch. Thank you so much, each one of you, for joining me. But before we dive into the featured paper, let's learn a little bit about each one of you. Could you talk to us about your current role, your area of work, as well as your academic interests? Francisco, why don't we start with you?
Thanks for having me. My name is Francisco Contijoch. I'm an associate professor in bioengineering and radiology here at UC San Diego, and I develop new cardiopulmonary imaging methods.
Phenomenal. Albert, how about you?
Yeah, I'm Albert Hsiao. I'm interim chief of cardiothoracic imaging, thanks to Seth, at UCSD, and lead an AI research lab in cardiovascular imaging.
Excellent. And lastly, Seth.
Seth Kligerman, chairman of radiology at National Jewish Health in Denver. And while the paper was being written, I was division chief of cardiothoracic imaging at UCSD. Various forms of research in ILD, CTEPH, congenital heart disease, and a couple other things, but definitely not as technically savvy as Albert or Francisco by any means.
Well, fantastic. Thank you, all three of you, for joining on the podcast. Let's go ahead and get into it. The paper that we're discussing today is an original science paper that covers a novel multi-energy CT technique in characterizing CTEPH, or chronic thromboembolic pulmonary hypertension. Let's break down the technique a little further. Let's start by talking about this concept of hypoperfused lung volume. Could you talk to us about the significance of HLV and how it's derived from chest CTA data? Francisco, why don't we start with you?
Sure. So I wanted to start by saying that the first author, Elizabeth Bird, she's an MSTP student, and so she's actually back in the clinic doing her clinical rotations. But so she really led this project, and I think her background and kind of MD, PhD training is kind of brought out by the interdisciplinary nature, I think, of what you'll hear us talk about today. She basically had this idea of quantifying exactly the territory that is hyperperfused in CTEPH patients. And so looking at multi-energy methods, they previously have captured kind of an average in the lungs of perfusion by kind of averaging across all of the lung pixels. And in working with some of the surgeons and pulmonologists that are also kind of co-authors, we realized that this was kind of a missing area of quantitative evaluation. So Liz put together a really nice pipeline. We took a automatic AI segmentation tool that Albert's lab had built to first define the lung areas and the lobes. And we used that to then interrogate the pixel values in the parenchyma. And so we could come up with an automatic quantitative way to look at how much of the lung is hypoperfused. So we had to do a bit of technical development to figure out exact thresholds for what we call hypoperfused. But at the end of the day, we now have a method that tells us as a percentage of the lung volume how much is low. And also we can look at it lobe by lobe thanks to the labeling that's done by the segmentation tool.
Could we get a little more granular with regards to what is meant by low or hypoperfused? Has this been adjudicated against other methods in multi-energy CT or adjudicated against in vivo techniques?
Yeah, I think that was one of the interesting things we struggled with, I think, is that the lung perfusion is obviously difficult to quantify, especially from a single time point imaging like we do in PE studies. And so here we kind of came up with a couple different tests to give us confidence that it seems to be accurate, but we didn't have a kind of adjudication with other pulmonary perfusion metrics, at least not in this study, or at least not yet.
Got you. And you had mentioned that the pixel by pixel analysis was performed after a registration technique that Albert and Albert's colleagues in his laboratory had developed. Albert, could you briefly talk about some of the significance or at least the novel components of that that anatomic reconstruction technique for us?
Yeah, I think we had previously developed a nice lung segmentation algorithm that could divide the lungs lobe by lobe. To elaborate a little bit further on what Francisco had described, really what we saw as a major sort of interpretive barrier in CT is really trying to map out the areas of the lungs that were hypoperfused relative to where the vascular stenoses were. That is a key sort of cornerstone, I suppose, of what CTEPH is. It's a disease where the pulmonary arteries are obstructed, leading to downstream hypoperfusion. So since there are so many other disease mimics and diseases that can cause either narrowings of the pulmonary arteries or malperfusion, we wanted to sort of match the two. And if you can match the two, then you can better understand whether or not it is indeed CTEPH, and then ultimately decide which parts of the lungs needed better perfusion, which areas for the surgeons to target for embolectomy, and then ultimately be able to correlate that with a surgical specimen. The segmentation algorithm is actually the same segmentation algorithm that we previously talked about in a previous podcast with you on our COPD algorithm. So this is actually another application of that lung segmentation algorithm with additional post-processing that Francisco's team continued on with for CTEPH specifically.
Fantastic. This may sound like a bit of a rudimentary question, but is this technique intending to generate something akin to an advanced perfusion scan that we would see with nuclear medicine imaging?
Yeah, there's a great correlation in our experience between what we see in dual energy CT and lung perfusion scintigraphy with the macroaggregated albumin. I think that's our general experience. So the goal here is to develop that same sort of map and understanding. Since it's not always possible to do both exams, then it's helpful to get it all in one.
Yeah, I mean, I really think I agree with Albert, and as we've been saying for years, just of our experience at UCSD, they're really, and I think the pulmonologists now are realizing this. A lot of the issue was back in the day, or even still, a lot of CT angiography techniques are suboptimal, and a lot of radiologists don't know how to recognize CTEPH in general. And so even though the studies would be positive, they'd be read as negative. This is single energy, monoenergetic CT. And so they became reliant on the VQ scan, not necessarily for the inability of CT detected, but more, I think, on the protocol and radiologist side. And what we've noticed with dual energy is that it is, in these cases, it really is a highly, a technique with extremely good spatial resolution that basically shows the hypoperfusion at a level that you just can't get on these 3D reconstructions you get with most VQ scans. Now, SPECT, yeah, it can be it will look pretty identical. But, I think this technique could easily replace VQ scan. And I think also one of the main benefits would be looking at pre and post-operative imaging and really assessing improvement in local perfusion and reperfusion compared to what you can get with VQ scan with these large, basically volumetric 3D slabs.
Seth, pardon my parlance here, but I love the hot take of potentially replacing VQ scans there. I just have one more question before we get into the study itself. Many of our listenership may be familiar with other multi-energy CT metrics for evaluating pulmonary perfusion. For example, pulmonary blood volume. How did the hyperperfused lung volume that you've evaluated in your study differ from pulmonary blood volume or other multi-energy metrics?
Right, pulmonary blood volume is basically assesses the entire lung. There's no spatial information provided with it. So you could theoretically have, a few segments that are, someone say if someone has level 4 disease and they have a few segments that are completely hypoperfused, have no perfusion or severe hypoperfusion, but the PBV technically would be normal. Because one is looking at the global perfusion, whereas the hyperperfused lung volume is really looking at regional information. So I think this technique is, in my opinion, far superior, at least for CTEPH. But I'll let Albert and Francisco probably answer that to a better degree than I can.
No, I think that description's perfect, Seth. I think, they are derived, we use the same type of dual energy images that you would use to do PBV mapping or assessment. We actually did it side by side in the paper for those that are interested. But this idea of giving us a territory of area that's hyperperfused as opposed to averaging all of the pixels together is, I think, the key difference. There's one normalization that you do in PBV that we didn't do, and that is, I think, the only kind of numerical difference besides this quantification. And so, yeah, I think on the overall level, we have a couple of examples in the paper exactly showing what Seth mentioned here, a normal PBV, but still pockets of disease that were treated surgically, and we actually show the surgical specimen that was removed. So in that sense, if you're looking at little pockets, they can get averaged away. And that was one of the benefits we think for HLV in comparison.
Let's jump now then into that paper and start with a discussion about study design. So this was a single center observational study. Y'all started with about 400, almost 400 consecutive patients, and they had undergone a multi-energy chest CTA, the PE protocol CT. It was relatively recent, 2018 to 2020. And the method of CTA acquisition was with a rapid KV switching technique. So then these patients were separated into the normal cohort and the CTEPH cohort. From here, can you take it away and describe what sort of data were collected from these cohorts and how certain comparisons were made?
Yeah, so we were building this new technique, and so we really wanted to come up with essentially a control comparison cohort where we could establish a bit of a baseline and kind of what's the normal values or normal variation in what we're seeing on the dual energy scans, and then obviously a CTEPH cohort. So we basically picked CTEPH patients that went on to get surgery. Obviously, there's patients that might be put on medical therapy or undergo balloon pulmonary angioplasty. Those are kind of a bit less kind of conventional cases in some ways in terms of the patterns that we expected to see. And then also we wouldn't have the surgical specimen after the fact to compare ourselves to. So on the CTEPH side, we essentially looked down the road to see if they ended up actually undergoing surgery. Some of the scans we did also were done after surgery. And so we removed those as well. So these were all preoperative scans in people who went on to get surgery for the treatment of their CTEPH. On the normal side, or on the control side of things, we essentially removed patients that had positive findings that would affect their lung perfusion. So if they actually had, they were scanned for under a PE protocol, if they had an acute PE, if they had any other kind of abnormalities that we thought could impact their pulmonary perfusion, we removed those again to kind of come up with a comparison group of what we thought would be a normal or a control lung perfusion.
Could you talk a bit about how the HLV, the hyperperfused lung volume data, were interpreted? Was this done separate from the raw images? And if so, who was performing the interpretation?
So in quantifying the HLV, we actually basically analyzed two sets of images that came off the scan. We took the monoenergetic images, and that's what we used to do the lung segmentation that Albert's lab had developed. And then we basically mapped that or just kind of applied that to the iodine water images that come off of the dual energy scan. And that allowed us to focus in on the parenchymal iodine values. That was it in terms of the quantification. So that came out as quantitative reporting automatically. We did in the study compare ourselves to what two radiologists would deem the perfusion to be in each of the lobes. And there we had Seth and another one of our colleagues grade the lobes in all of the CTEPH patients, and then we were able to look at how much the HLV agreed with the visual assessment. But from a HLV perspective, it's fully automated.
Got you. And before we go into the diagnostic and prognostic components of HLV, let's talk about how it compared to the radiologists. How did HLV compare to the visually assessed hypoperfusion by our radiologists?
So basically, it was moderately correlated in a nice kind of stepwise fashion. There's a nice table or a figure at the end of the paper showing how in cases where there's essentially no hypoperfusion as judged by the radiologist, there's very low HLV scores in those lobes. And as you would expect, as the radiologist grades the hyperperfusion to be more and more severe, we see kind of a stepwise increase in the HLV in that lobe. So that is a great kind of confidence that what we're quantifying essentially is what the experts here would judge anyways.
Now, CT isn't necessarily part of the diagnostic algorithm for CTEPH per se, but out of curiosity, how did HLV quantitatively perform in the identification of CTEPH or diagnosis of CTEPH, if you will?
Just real quick, I think CT is part of the diagnostic, right? I mean, right, I think the step is if you have someone with pulmonary hypertension, you have a VQ scan that's abnormal, then you would go to CT pulmonary angiography for assessment for CTEPH. So I think it's still part of the algorithm. It's just not the first, it's not your gatekeeper of negative VQ, don't do anything else, and positive VQ, then you keep going on.
Perfect. Thanks for the clarification.
Sorry. I think it's good to sort of reflect on that a little bit. If you take a step back to sort of the diagnosis of CTEPH from the point of view of our pulmonary vascular colleagues, what's commonly observed is that a lot of patients with CTEPH have negative PE studies, in large part because staff, radiologists, will read PE studies for acute PE, but the findings of chronic PE can be very, very subtle. And so it's because of that VQ or perfusion scintigraphy has been the dominant sort of screening modality. It's because that our ability to detect CTEPH on CT angiography as a specialty is not as good as it should be or as it could be. So really, that's what's driven that VQ as the initial test. And if it's positive, then certainly patients should undergo a high quality CT angiogram of the pulmonary arteries to evaluate that. But I think out there in the community, there's probably not a lot of awareness of the subtle signs of CTEPH, and so this is an ongoing issue for many decades now. I think we do have a role to play in improving that, and and then certainly then we currently use dual energy CT as a surgical planning step, which is why we had so many patients in our study.
Excellent. I think that this point of clarification and subsequent discussion speaks to where the initial diagnostic components of the disease have come from, and that's has not initially derived from CT. But my question is, can it? And can we modify some of the currently established guidelines for initial diagnostic evaluation to include other imaging modalities, in this case, CT? This is more speculative, of course, but curious to get y'all's takes on that.
Yeah, no, I remember I was speaking at a CTEPH conference in San Diego. I don't know if it was a year ago. It's probably pre-COVID, actually. And I raised that whole topic of, if you have dual energy scanners, even good, standard scanner with good, and you get it, again, it has to be, spatial resolution really has to be sub-millimeter. I mean, I read these at all 0.65s and now 0.4s. And I brought up the idea of, replacing VQ with a CT if there is concern, because obviously CT provides a lot more information than just perfusion. And I wasn't, the pulmonologist or the surgeons didn't laugh at me, but they said, I live in a very academic fantasy world that, out in the general population, you don't have subspecialty trained cardiothoracic or cardiovascular radiologists interpreting your studies on these high-end scanners with this functionality. And that, yes, you could, if everyone was as, this is what they said, as well trained as people are at UCSD or other major academic centers, but, in the real world, that just wouldn't hold true. So I think it's not a technology failing. I think it's a failing of our education and knowledge of what CTEPH looks like on CT. But I think with dual energy, I just had a case yesterday where we had a CTEPH person, and I caught the disease, but I missed that there was, disease in the inferior segment of the lingula, and the perfusion iodine map showed me clearly that there was no perfusion there. And I went back and looked and said, oh, there's missing perfusion there, and added that to the dictation. So I think dual energy is definitely a step forward in it. However you want to acquire, your multi-energy CT. But I think to take that to a level outside of academic centers would be difficult. That's my that's my 2 cents.
Yeah, I can certainly speak to some of what we see in the community too, and it's exactly that, where there may not be a lack of equipment or software per se. There's quite high-end software and hardware that's out in the community, but there may be just a lack of familiarity or education from some of our more general radiologists in identification of those subtle features of CTEPH. And one wonders whether quantitative metrics such as this one, such as HLV, can help enhance our general radiology population to better identify those things that may really only be picked up by the experts in the field.
And it's not just that. The amount of studies we used to get from outside that were CT scans that were 3 millimeter slice thicknesses, or even 2.5, 2 millimeter slice thick. You're just not going to see distal segmental and subsegmental disease very well. You're just not. And we know there's a fair amount of people that have isolated disease to the subsegmental level that our surgeons can treat. So they're just handcuffing themselves by their protocols as much as their lack of knowledge of the appearance of CTEPH.
One thing that I think is really exciting right now is that we have the ability to develop these AI algorithms that can run pretty much autonomously. I think this algorithm that Francisco and team have built on top of this lung segmentation algorithm doesn't require any manual intervention to generate the color map, and it can do this really reliably. And I think that's really the power that deep learning gives us now. We can produce really highly reliable algorithms that can help physicians of all levels of expertise become better and read more like experts. I think that's the exciting period we're in now, if we can get these algorithms out there.
100%. The stuff that Albert and Francisco are doing are really going to make our lives a lot easier and make us more accurate. That's for sure.
And it's studies like these that help demonstrate not just to other radiologists, but to our consultants that there is veracity in the claims that are being made from these quantitative metrics that we're deriving from CT that may or may not be visible subjectively by our even expert radiologists. To that end, Francisco, could you guide us through an understanding of how HLV compared to some of the invasive assessments that were done in your patient cohorts, as well as how and if it predicted improvement following endarterectomy?
Yeah, so I think we had a couple comparisons we did in the paper. Kind of some of them are kind of housekeeping-ish in the sense that you would expect hopefully a metric like HLV to be higher in patients that have more disease, kind of as measured by invasive hemodynamics, and we saw exactly that. So HLV correlated moderately with their preoperative pulmonary vascular resistance and fairly with the mean pulmonary artery pressure and cardiac output. We also then looked at patients' hemodynamics after surgery, and HLV was moderately correlated with the change in their PVR. So we didn't control for any of this. We weren't recruiting any type of patient cohorts. This is kind of what was going through the clinical pathway here at UCSD, but that gave us confidence that if we see more HLV, that means there's more disease. It then also seemed like that meant that it could be treated. Obviously, that's a complicated surgical question that should be further studied. But those were two outcomes that we had because we had the surgical patients had follow-up hemodynamics on.
So there's a lot to unpackage there, and I think we can get into some of the clinical significance, particularly in the surgical realm, in just a moment. But before we get into that, I wanted to discuss quickly some of the limitations of this particular study. So besides talking about the expected limitations with single center studies or observational studies, is there anything important to note limitation-wise about this particular study?
Yeah, I think that the ones, I guess I would bring up one or two just to kind of highlight maybe part of the conversation earlier. So we compared ourselves to control cases just to kind of check that the HLV separated the two, but this wasn't done in a kind of diagnostic way where patients were coming in and we were trying to diagnose them with CTEPH or not. So that question I think needs to be studied in a dedicated cohort. We also didn't look at other types of CTEPH cases, like I said, people who weren't surgically treated, whether they weren't eligible for surgery, declined surgery, or underwent a different pathway, whether it was a balloon pulmonary angioplasty treatment or medical therapy. We also didn't, unfortunately, have more insight into the surgical specimens besides the pictures we showed. Obviously, if we could ask our surgeons, in the future to tell us which vessels they consider to be closed or obstructed, that would be a better set of outcomes that we could try to match our imaging to. And unfortunately, we don't have a lot of longitudinal imaging done here, so we didn't have kind of the post-surgical maps that I think would be really nice to show the improvement, as Seth alluded to earlier, being recorded by the dual energy maps. So those I think were the big ones that we're hoping to probably investigate in the future in some follow-up studies.
Yeah, no, it's one thing I really think preoperative and postoperative dual energy imaging, because we do preoperative and postoperative VQ scans, and it's funny. Our surgeons are the best surgeons in the world for CTEPH. I mean, they are just amazing. But if you do imaging on a lot of these patients afterwards, you'll see areas that they just either can't get to, not big central areas or even segmental areas, but maybe some distal segmental or subsegmental areas that they can't get to. And it's one of the things I said, why don't we get postoperative imaging? And the surgeons kind of laughed. It's like, oh, I don't want to see the stuff I didn't get to. I don't want to think that, I'm perfect. And I don't want to see that little apical-posterior, subsegmental branch in the left upper lobe I just couldn't get to. But all joking aside, I think that I really believe that outcome measures will be much highly and better correlated with CT, dual energy CT pre and post changes than standard VQ imaging. There's no doubt. The changes in even right heart morphologies we see immediately post-op is striking. And I really wish that they would do CT, because the dose is a little higher. Obviously, you got to get contrast, but we're not talking astronomically higher doses of radiation. I think that's something that I would love UCSD to start doing.
Anecdotally, from CTEPH conferences that we've attended, one of the most common questions that we get asked is this surgically amenable disease? And we don't have the UCSD surgeons, not to say that our surgeons are not super well trained, but they may not have the aggression to go after some of the far more distal disease. But we're presented with scintigraphy, which has a relatively rudimentary spatial resolution, and comparing that to just standard CTA of the chest. And there's oftentimes for lack of a better word, a mismatch between the areas of perfusion defect that I'm seeing and the segmental or subsegmental arteries, which look otherwise pristine. Does HLV have a role there, or a metric that's derived from multi-energy CT, to push our patients into a potentially more surgical amenable spectrum?
I mean, I would imagine the HLV would, show similarly, hypoperfusion like the VQ scan, and you would rely on CT. And also, I mean, I don't know how they do it at Mayo. I know that most of our patients, the vast majority, still get direct catheter angiography, and but even those to me are a little outdated. I have to say the amount of cases where there is clear hypoperfusion without an associated airway abnormality. I mean, we know that hyperperfusion can happen because of hypoxic vasoconstriction, fibrosis, emphysema, blah, 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 where you have a pristine looking lung where there is no clear airway abnormality or parenchymal disease, and a hyperperfusion that's isolated to a vascular boundary where the CT looks relatively normal, and you have a good technique. I mean, good slice thickness, good bolus, no motion. I haven't seen a ton of those. I'm sure I've seen them. I wouldn't know how to put those two together. I don't know, the HLV technique would definitely show the hyperfusion. I don't know without the anatomic correlation what to do with that. I mean, that's me looking at it as a radiologist. I don't know if Francisco or Albert have anything to say to that.
Yeah, I think maybe we didn't compare ourselves to the VQ scanning in terms of what we see maybe in these types of cases. Does the HLV paint a picture more like the VQ scan, and that it would show you an abnormality, but you would still be stuck with kind of the upstream vasculature being clean, or would it kind of fall more in line with an upstream vasculature that's not obstructed and kind of show normal? We didn't look at the VQ scans, and I haven't come across any examples of that to kind of help clarify that. But I think our hope is that it starts to give us more VQ-like information to complement the fact that the vasculature is red, looking for obstructions or lining thrombus and those types of assessments. You would hopefully then be able to pair that with these lobar metrics telling you that there is a downstream effect.
I guess zooming out then, is a technique like HLV or anything derived from multi-energy CT meant to be a complement or a supplement to other perfusion-based techniques in the diagnostic workup for these patients with CTEPH?
Yeah, that was one of the limitations I said, is that I think we framed it as, we compared ourselves, for example, to PBV in terms of whether it provides new or unique information. But I think it should be, thought of complementary to PBV and any other metrics. You're trying to build, I think, this agreement between the obstructions you see in the vasculature, the downstream territories that are affected. Ideally, the surgeons want to see an obstruction that if they remove, they would, improve the downstream hyperperfusion. So if any of those are kind of not in agreement, I think that would be worrying, and building quantitative tools to test that is part of our broader goal. So I do think it's probably complementary to hemodynamics. I think it's complementary to the vascular findings, the clinical picture. Any of the other kind of studies that are performed, I think, would hopefully complement this, but hopefully we're getting more of a quantitative assessment than what we've previously had.
I think it's complementary. I mean, I think at some point it could be a replacement, but right now I think we see it as complementary.
Any future work on the horizon with regards to multi-energy CT evaluation of perfusion or specific to HLV?
Yeah, I think the studies we envision probably are well described by some of the limitations I mentioned earlier. Looking at different subtypes of CTEPH ahead of time. We did this observationally, so some of the distal disease cases weren't as highly represented in our sample as we would have liked. patients who are undergoing BPA or medical therapy, looking to see if there's changes in their HLV before and after their treatment. All of these, I think, how this actually can change some of the clinical decision making. Does it help you with planning a procedure, or like you said, identifying surgical operability, which is a hot topic? I think those will all be things we're interested in looking at in the future.
Albert and Seth, I'm curious to know how you integrate, if not HLV, some of the understanding that you've gained from the power of these multi-energy CT techniques into your current clinical reporting for your surgical or pulmonology colleagues. Could you walk us through your approach to a complicated CTEPH case? You can be as general as specific as you would like.
That's a good question. I have at UCSD, I had a very, very detailed template that went through every branch, basically, up to, segmental, subsegmental for every segment. So we broken down into a basically almost like a segmental chart talking about. So I start main PAs, lobar, and then get to the 3 segments in the right upper lobe, 2 in the right middle lobe, 5 in the right lower lobe, and then talk about the segments, subsegments. And I would have, for me, the 0.625 anatomic CT angiography, where depending on the bolus, I may use the monoenergetic KEV, use a low KEV to manipulate the data if we got a bad bolus to try to make it a little more, the iodine a little brighter. And then next to that, have the iodine map directly next to that. And I would scroll through and literally pick out every segment, and even to the subsegmental level, talk about disease, talk about whether it's obstructive or non-obstructive, right? I mean, that's one of the limitations of perfusion, is that you can have a lot of disease that's non-obstructive. That's not going to lead to a perfusion defect. You get a lot of webs and bands, so on and so forth. So we'll literally just go through each area and mention if there's disease, mention if it's obstructive or non-obstructive, and then mention if there's an associated perfusion defect associated with that obstruction. So they would be, my CTEPH reports would be very long compared to, I'm usually pretty terse in my reports, would be very long. And then I kind of draw a little map basically from my dictation, not physically, but at least mentally you could picture it. And then we would, in our CTEPH MDC, go through, all those findings at each level. And, the surgeons would come together with a treatment plan. And our surgeons were, again, they're just fantastic. There's things that I'm just shocked. They're like, oh, we'll get that. I'm like, how are you going to get that? It is so distal. And they're like, oh, we'll get that, no problem. And sure enough, they do. And we get, the follow-up. Again, I wish there was a CT, dual energy CT or multi-energy CT on follow-up, but even the VQ scans would show that these, very distal areas were now reperfused. So it really was a pleasure to work with them. But anyways, they were very detailed scans compared to my acute PE studies or most of my other studies.
Yeah, that's exactly the same way that I read too. I'll bring up the perfusion map and then look for the upstream vessel. If those are aligned, with CTEPH, the vessels aren't necessarily, you won't necessarily see clot, right? So sometimes the finding is really just diffuse narrowing to a caliber that's unusually small for that branch. And when something is diffuse, we all know in radiology that it's quite difficult to notice unless you have the reference point in your mind of a normal patient. So I think it's a good clue when you see these areas of hypoperfusion to look more carefully at the caliber of the vessels. And I think if you think about that fundamentally, it's because those clots that resorb end up being a scar. That's ultimately what the surgeons are removing from the pulmonary arteries. So I approach this very similar to what Seth has described. Look at the perfusion and then look at the pulmonary artery branches upstream.
Amazing. Y'all, I think this has been a super comprehensive and very interesting conversation relevant to many of our listenership. Wanted to get some of y'all's final thoughts before we conclude. Francisco, why don't you go ahead?
I just wanted to thank some of the folks that aren't on the call here, which would primarily be our pulmonologists and surgical colleagues, the co-authors on the paper. And obviously, this is an imaging-focused paper and study, but it wouldn't have been possible or even practical without their expertise and their work. And I think it's really a testament to this multidisciplinary practice group and obviously research that we're trying to conduct. So a thank you to them. And like I said, Liz Bird, who's back in the clinical arena, really led the study. So I just wanted to mention her again.
Perfect. Thanks, Francisco. Albert?
No, this has been a great opportunity to share what we've all been thinking a lot about over the last couple of years, at least the three of us. Hopefully, other folks will become more interested in this uncommon but really important disease and treatable disease. I think that if that brings more interest into this area, that would be great.
Awesome. Thanks, Albert. How about you, Seth?
Yeah, no, I mean, it was the great joy of working at UCSD beyond the people in my section and working with Francisco and Elizabeth. We're working with the CTEPH team there. And really, it is a disease. I mean, I have cases. So I worked before that at University of Maryland, and some very good radiologists there, to say the least. And I remember I had cases saved that were sent, showed to me being CTEPH, and that were not. They were either in situ thrombus and PAH and so on and so forth. So you realize how even very good radiologists can miss the diagnosis or make errors in diagnosis. And just becoming, for a few years, an imaging expert, which took a lot of work because I didn't know what it was when I first got there, but slowly becoming an imaging expert in CTEPH was one of the great thrills of my career. And long working with Francisco and Elizabeth and Albert and Lewis and Misha and the whole group there, Liz, it really was a fantastic journey. So very sad. I'm almost a little verklempt here talking about it. But anyway.
We miss you too, Seth. We miss you.
Thank you.
Amazing. Thank you, Seth. Thank you to all three of you, not just from myself, but from the whole radiology community for these contributions to the science. We really rely on the expertise from the three of y'all and y'all's lab and those that have contributed to this to further our understanding of this extraordinarily complex disease process. So for me, on the behalf of everyone, thank you very much.
All right. Thank you, guys.
All right. And that brings us to the end of our conversation. To our listeners out there, of course, thank you for tuning in to the podcast. If you like what you hear from us, please rate, review, and subscribe to us. Once again, this is the Radiology Cardiothoracic Imaging Journal podcast. See you next time.